Hello guys, welcome to our Sureshot series. Today we are going to discuss about the ECG part 2. So last week we have discussed bradyarrhythmias, tachyarrhythmias and also the ECG and basics. Today we are going to discuss about the ECG part 2, especially ST elevation, U waves, J points and also Osborn waves and some of the specific findings of the pericarditis, dioxin toxicity and also electrolyte imbalance. So before we start the topic, please do subscribe and share with your friends. So recently we have updated the RRR edition 1. So this is the rapid review notes. So that will cover the all entire 19 subjects and high topics. So I highly recommend please do refer and join in the Telegram group. There you can access to the PDF. So let's start our video. So first thing that we have to understand what is the U wave. So see guys, we all know there is a P wave which is your atrial depolarization and QRS complex that is your ventricular depolarization and T wave that is your ventricular repolarization. What is this U wave? So U wave is specifically it is a papillary muscle contraction. So when there is a contraction in the inside the papillary muscle that will cause the U wave. And also ventricular late repolarization can also cause the contraction of the U waves. And there is this causes like hypokalemia. So patients those who are having the hypokalemia and also patients those who are having the hypomagnesemia and also patients who is suffering from the hypothermia. All these patients are going to present with the U waves. And what is the treatment? Mostly U waves are not considered to be the very considerable notice in the ECG wave say changes, but U wave it could be normally due to papillary contraction or the late ventricular repolarization or delayed ventricular repolarization. Most commonly in the pathological conditions like hypokalemia, hypomagnesemia, hypothermia, it is seen. And even those who are having the increased intracranial tension is also sometimes it is seen. So next one is your J point. What is the J point is? Always remember your J point is the junction between the ventricular depolarization and it is also junction between the ventricular repolarization. So this will going to differentiate between the ventricular depolarization point and ventricular repolarization point. J point is equal to all isoelectrical lines. But in case if the patient is presenting with a chest pain or any pathological condition, that the patient is J point is elevated from the basal lines of the J point, that is a significant change that might be, it could be ST elevation, or if there is a depression, then it is a NSTEMI, or patient might be having the other pathological conditions like cardiomyopathy is also present. So the J point will differentiate whether the pathology is above the junction or below the junction. That's how you can differentiate. But there is a specific point that is seen. This is your Osborn waves. Here you can see the Osborn waves is nothing but it is a end point of the QRS complex, but there is a bifid pathway like this kind of presentation is known as the Osborn waves. And Osborn waves is not an ST elevation. Okay, it is not an ST elevation. It just mimics the ST elevation, and it is most commonly seen in the hypothermia patients. Okay, so don't confuse if you see the ECG point with the Osborn waves that is seen in the hypothermia patients, just an extension of your QRS complex. Next, moving on to the electrolyte imbalance of the hyperkalemia and the hypokalemia. What are the changes that specifically present in this patient? When I say hyperkalemia, it is commonly in the more than 5 millimoles of the potassium levels in the blood. What are the changes that specifically seen, especially your T wave changes? How the T waves are going to present it is tall and the peak T waves. So here also in the ECG, here you can see the T wave is completely elevated. So these are the first finding that you can see, and it will also show the ST elevation in the ECG. So the ST elevation, the T tall waves is commonly presented. And also here you can see the broad QRS complex. Okay, the QRS complex is going to be the broad and the prolonged PR interval. Okay, prolonged PR interval. Here it is more than 120 milliseconds. So it is a prolonged PR interval. What is the treatment of the choice? Usually this can cause the severe diastolic arrest in the patient. So if the patient is having a more than 80 millimoles, so it will easily cause the patient cardiac arrest. So what we can do in this patient, we can give the treatment with the IV calcium gluconate. Okay, IV calcium gluconate, you can give the immediate treatment for this patient. So next moving on to the hypokalemia, what are the changes? So the T wave is usually flattened. Okay, the T wave is usually flattened, and in this patient sometimes there is a T wave depression is also seen. All right, T wave depression is also seen, and as we discussed beside the slide, there is a prominent U wave, right? There is a U wave is also present. And how about the QRS complex? QRS complex is usually QT prolongation. Okay, here you can see there is a QT prolongation, same as your PR prolongation. Okay, the PR interval is also prolongation. So what is the treatment of the choice in this patient? You can give the KCL IV. So which is more dangerous? So the hyperkalemia is more dangerous because it can cause the diastolic cardiac arrest. All right, these are the prominent changes that we will be seeing in the hyperkalemia or the hypokalemia changes. So next moving on to the hypocalcemia. What is the hypocalcemia or the hypercalcemia? When we say the calcium is indirectly proportional to the QT interval. So if the calcium levels is low, so there is a high chance of the QT prolongation. If the calcium levels are very high, then the QT interval is short. So this is how the patients presented with the hypocalcemia, the hypercalcemia. And there is this question, which of the following will trigger the patient's torsades, depointers, or the severe QT prolongation, death of the cause in this patient? So then that is your hypocalcemia. So the torsades is a very risk in the hypocalcemia than the hypercalcemia. So the torsades is not seen in these patients. All right, that is the one question. And digoxin toxicity is also associated. Which one, guys? So the digoxin toxicity will be associated. You have to answer after the next slide. So we will be having the digoxin toxicity in the next slide. You have to understand which will causing the hypocalcemia, the hypocalcemia in these patients, which will be associated with the digoxin toxicity. So next moving on to the our digoxin toxicity. So in this patient, those who are having the digoxin toxicity, what is the mechanism of action that we have to understand? So when we give the digoxin to the patient, so this is the mechanism of action. So digoxin will usually on the sodium and potassium ATP pump, it is going to inhibit this pump. All right. So usually it will block this entire potassium and the sodium ATPase pump. What will happen? So that inside the cell, so instead of the exchange of the potassium and the sodium, so the sodium is going to increase in the myocyte of the heart. So myocyte of the heart will be increased sodium. So indirectly, this is also going to decrease the sodium and the calcium exchanger. So the intracellularly, the increased calcium will be seen, and end of the point, this will increase the contraction of the heart. So this is your mechanism of action of the digoxin. What happening in the digoxin toxicity? Usually you are going to block the sodium and potassium ATPase pump is blocked, so that your sodium inside the cell is going to build. So that will further decrease the sodium and calcium exchanger. So it will increase the calcium levels inside the cell, and furtherly the contraction will be, or the ionotropization will be increased in this patient. So what is the ECG changes that we will be seeing? So there is the spooked pathway. So these kind of spooked pathway is seen in the patients of the digoxin. So this is also known as the hockey stick ST changes or the spooked ST changes of the patient. And this is also known as the salivary. The salivary sagging, these kind of words you might have heard. The salivary sagging or the spooked salivary sagged or the spooked ST changes that is seen in the digoxin patient. And also the T wave is inverted in this patient. So the T wave inversions is also seen. As we discussed here, the calcium is going to increase. So that means the QT prolongation will be decreased. The QT will be shortened. And also U waves is also seen in this patient. How about the PR interval? The PR interval is also prolonged. So the PR interval is also prolonged. So these are the specific changes that is seen in the patients of the digoxin toxicity. So next moving on to the ST elevation, guys. What is the ST elevation that we have to understand? As we have seen that before, there is a ST elevation or the ST depression will be differentiated on the J part. But how to, we have to look at this ST point. So you have to remember that we have the 12 lead ECG, right? One is your chest leads and another one is your limb leads. So how many number has to be the increase so that we can say this patient might be having the ST elevation or the ST depression. In the chest leads, it must be the more than 0.2 MV amplitude, and in the limb leads more than 0.1 millivolts of the 0.1 millivolts of the amplitude in the limb leads. So that means, so the 1 mm or the 2 mm it should be of the small boxes so that we can say there is a ST elevation of this patient. All right, but how to see the ST elevation, whether the patient is presented with the severe chest pain, but the patient ST elevation is seen, but the troponins are normal. What we can go for? It might be the MI or not. How can we confirm? But we have to confirm by the markers only. And the patients, those who are suffering from the ST elevation, usually there will be troponin positive. In the non-ST elevation, the troponin will be negative only, most of the cases. And we'll also understand the what is the treatment protocol for this patient. All right, here you can see this is the ST changes that is classically seen in the STEMI patient. And in the non-ST elevations, there will be a ST depression or the T wave inversion. So this is commonly seen in the patients of the non-STEMI patient. How about the treatment of this patient? So let's see that the patient is presented with the STEMI. So what you have to give in these patients, you have to go for the MON. What is this MON, guys? You have to give the morphine, means the painkiller should be given in this patient, and also O2 therapy, oxygen, and start on the patients with the aspirin. And what is this drug? This is your nitroglycerin. So the vasodilator that we have to give so that the patient, the ischemia chances will be decreased in the heart. So this is the one protocol, but ultimate protocol is the PCI intervention only. So how to do the PCI intervention? So whenever the patient is presented with the ST elevation within the 90 minutes, so the door to balloon time is the 90 minutes only. In this 90 minutes, you have to go for the PCI of this patient, or you have to go for the CAPG. Depends on the angiogram, the patient outcome, you have to do the PCI of the CAPG for this patient. And how about the non-ST elevation? So let's say that the patient is presented with the non-ST elevation. In this patient, you have the different categories. Let's say that the patient is having the very, very low severity. So the troponins is normal. The patient ECG change is also not significant. Then you can usually within the 72 hours, we can go for the PCI intervention. And how about the moderate? So the moderate or the severe patients, then you have to do in the within the 12 to 24 hours, you have to do. Okay, so 12 to 24 hours you have to do. If the patient is having the severe, like only the ST depression is seen, but troponins are very, very elevated, then within the 2 hours, you have to move on to the PCI intervention. Let's say that the patient is not in the PCI center. So what you can do, go. So if the PCI center is not available, so the PCI center is not available, so you have to shift within the 120 minutes to the next nearby PCI center and do this intervention. So in this meanwhile, you can go for the patient. If it is more than 120 minutes, then we can do the thrombolysis. Okay, then we can go for the thrombolysis. So this is how the normal protocol that is must be followed for the MI. So how to see the which of the following is associated with this patient. So we all know that we are going to use this different kinds of the leads, right? So this is your chest leads. So we are going to check where these all the waves are elevated and how the ischemia is started in this patient. So before that, understand this circulation. So in the anterior side of the heart, so if you see the anterior side of the heart, what is the dominant artery? So that is your LCA. On the LCA, how many branches here? So from the auricle, here you can see this is your anterior interventricular branch of the left coronary artery. Here this is your left circumflex artery and left marginal artery. So the main artery that is involved in this patient, that is the bladder. So the artery that is the most common and most prone to the disease is the bladder. So this is the most common artery involved in the MI. And in the right side of the branches, here you can see the right coronary artery is more majorly is going to give, and this is also going to supply to your SA node and the AB node. So this is the circulation that is done by your RCA. And in the posterior side, the majority of the artery is your still RCA only. So the most of the patients in the posterior side is dominant by the RCA than the LCA, the left coronary artery. But how to see which of the leads will cover which of the elevation? So on the lateral side, what are your lateral leads, guys? Your V5, V6, and AVL, and also your lead 1. These all going to presented in the lateral side of the heart, which will be elevated. What is the artery that is associated? Left coronary artery that is associated. And on the inferior side, we'll be having the lead 2, lead 3, and AVF. What is the artery that is involved? That is your RCA. And how about the next lead? That is your septal leads. Directly the interventricular septum will be involved. Here it is V1 and the V2. That is the most commonly LADA, because anterior side is dominant with the LADA. Next, anterior of the leads, that is your V3 and the V4 is also commonly associated with the LADA. So this is the arteries that is most commonly associated. So here your left circumflex artery, here right coronary artery, and here your left anterior descending artery of the both septal and the anterior side of the leads. So here you can differentiate how these presentations will be seen in this question. Next, here only we will be going to conclude the what are the MI markers that is elevated in the patient. So this is a commonly asked question. So what is the most common one or the most sensitively first one will be elevated? Always remember it is your ischemia modified albumin. So the most common or the first one to be elevated is the ischemia modified albumin, and after that the heart fatty acid. Okay, after that the heart fatty acid protein will be elevated. Followed by that your myoglobin will be elevated. Always remember the timeline is very important. So the earliest one is the ischemia modified albumin, and the next one is the heart fatty acid protein, and the third one that is your myoglobin. And if the no options is given, then you can go for the myoglobin itself. So the earliest to rise is the myoglobin if the options of this or this not given. So let's see the timeline of the frame. Here in this graph, we can easily see the myoglobin is the one which will be elevated earliest, followed by your CKMB or the troponin. What is the importance of the CKMB or the troponin? Remember that this is also elevated in the reinfection. The patient is having the severe reinfection immediately after 2 days or the 3 days, so that is elevated. So best for your reinfection is the CKMB and the troponin. What is the specifically important of the troponin? Because the troponin is the very specific. When you say MI, the troponin is very specific because it is elevated early and it is rise until 7 days. So that's why the troponin is very specific in the MI patients. So that's the one thing that we have to know. So the myoglobin followed by your troponins or the CKMB and then your LDH. Okay, the LDH1 that is also seen. So let's say this is less than 2 hours in the patient, then it is in that 2 to 4 hours. Then this will be more than 24 hours. And these two can be within the 1 hour. So this is how the timeline of the MI markers will be presented. And what is this LDH1? See, usually your heart will be having the LDH1. Okay, and LDH2 is present in the arteries. So if there is a MI, so what happens? These MI markers like LDH will be traveling into the arteries. So instead of the LDH2, we are going to see the LDH1 positive. Alright. So this is also known as your LDH2. Next, moving on to the ECG. Here you can see the ST elevation is seen, and also in the lead 2 is also seen in this patient. And here also the diffuse ST elevation is seen. The V5 is also ST elevation, and also here you can see the V3, V2, V1, V5, V6. All the waves are elevated. What could be the diagnosis of this patient? Not all the arteries are going to block, and all the arteries if the block, obviously the patient is going to have the ventricular tachycardia or the ventricular V5, but still the patient is having the all elevations. What could be the case of this condition? So this is the condition of the pericarditis. So whenever you see the patient will be having the diffuse ST elevation, that means that the patient might be having the pericardial pathology. All right. So how the pericarditis patient will be presented? In the first beginning of the stage, when the inflammation is started, the patient will be presented with the PR depression and the ST elevation. Here you can see the PR depression and the ST elevation is seen. And over the time, this is a chronic condition. Pericarditis usually is a very less prone to infection or the inflammation. But if it is an inflammation, easily in that 2 to 4 hours, 2 to 4 weeks, the patient will be affected. So this is the earliest. Within the 1 week of the patient will be presented as the ST elevation and the PR depression. So then the transitional will be seen. So the T wave is going to decrease. So the ST elevation is going to flatten. So that is what happened in the second stage. And in the third stage, ST wave inversion. Here you can see the inversion is also seen in this patient. And after the 4 to 5 weeks, let's say, this patient will be having the normalization of the complete ECG we see in this patient. And what is this one, guys? This is your Kodaic sign. Okay, this is your Kodaic sign. What is this Kodaic sign? Usually, when the patient is affected with the pericarditis, these patients will be having this specific finding. That is your Kodaic sign. The waves of this patient will be like this. Okay, sloping. Okay, this is going down. The ST segment is going down. That is known as the Kodaic sign. So always remember, please do revise the part 1 and the part 2 and understand the concepts, understand the ECG presentation and what is the drug of the choice. Please do remember. Always go with the image-based cancellation of the choices and choosing the best answer. And always remember, guys, focus on the high topics and the previous year topics when you are revising for the last minute. Understand the concepts, don't just memorize them. And practice MCQs. Daily 50 to 80 MCQs per day in this last 10 days is very important. So those who haven't joined our Telegram or the WhatsApp channel, please do join and please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects. So thank you.